Okay, let's dive right into this explainer and run through a rapid-fire update on managing dysmenorrhea. Imagine a 16-year-old patient sitting in your exam room just totally doubled over from cramps. As healthcare professionals, we see this chief complaint constantly, right? So let's look at the source material together and build a highly structured, evidence-based pathway to actually treat it. The data point here is honestly pretty striking. 50 to 90%. That's the percentage of reproductive age women worldwide who describe experiencing painful menstrual periods. It's a massive clinical burden. We're talking about leading to significant school and work absenteeism, sometimes hitting up to 20% globally. So this validates that we aren't just dealing with a minor monthly inconvenience. We are exploring a major quality of life issue that the literature shows is frequently underdiagnosed and, frankly, undertreated by the medical community. Here's our game plan for today. We'll start with the pathophysiology of pelvic pain, differentiate primary versus secondary cases, navigate the clinical evaluation and red flags, build out our first-line pharmacologic management, and finally, look at escalation for those tough refractory cases. Let's start at Section 1, Pathophysiology. We're going to zoom in on the cellular level to understand exactly why our 16-year-old patient is experiencing so much pain. Following the cascade, we can see the exact mechanism. As the endometrium sloughs off at the beginning of menses, you get a drop in progesterone and estrogen, which triggers the release of phospholipids. These are then converted into arachidonic acid, which drives the COX-1 and COX-2 enzymes to produce inflammatory mediators. Specifically, we're looking at prostaglandin-E2 and PGF2-alpha. These prostaglandins induce intense, non-rhythmic uterine hypercontractility. We're talking about intrauterine pressures frequently exceeding 150 to 180 millimeters of mercury, sometimes even pushing past 400. When uterine pressure exceeds arterial pressure like that, profound ischemia develops, and that is what causes that intense cramping pain. Moving on to Section 2, Primary versus Secondary Dysmenorrhea. This is really your first clinical fork in the road. Let's define our terms real quick. Primary dysmenorrhea is the presence of recurrent, crampy, midline pelvic pain during menses without any demonstrable disease. It's basically a diagnosis of exclusion that typically starts in adolescence pretty soon after ovulatory cycles establish. Secondary dysmenorrhea, on the other hand, presents with identical pain symptoms, but it's driven by a clinically identifiable underlying pathology, and it usually develops later in life as that underlying disease progresses. Notice the striking contrast in patient history here. A classic primary dysmenorrhea history involves pain starting maybe 1 to 2 days before or right with the onset of menses. It's localized strictly to the midline or suprapubic area, and it usually responds pretty well to NSAIDs. Secondary dysmenorrhea, though, throws up some major red flags. The pain might be non-midline or unilateral. It might start much later in life, and it's often accompanied by dyspareunia, heavy menstrual bleeding, or just a profound resistance to standard medical therapy. When you dig into the literature on secondary dysmenorrhea, these are the critical etiologies that should absolutely always be on your differential radar. Endometriosis is the massive one here, found in up to 80% of refractory cases. But you also need to actively consider adenomyosis, uterine fibroids, and prior pelvic inflammatory disease, which can leave behind painful pelvic adhesions. All right, Section 3, Clinical Evaluation and Red Flags. The crucial point here is translating that patient history into a focused, highly effective diagnostic workup. And this brings us to a super common clinical dilemma. When is a pelvic exam or imaging actually indicated for a young patient presenting with menstrual cramps? How aggressive do we actually need to be right out of the gate? Well, for our hypothetical 16-year-old with typical primary symptoms, the clinical evidence gives us a very clear pathway. You can confidently defer the pelvic exam if they aren't sexually active. A thorough abdominal exam and a detailed history are totally sufficient to start treatment. However, an ultrasound is absolutely indicated if the patient has severe refractory symptoms, if you suspect obstructive Müllerian anomalies, or if those first-tier treatments are already failing. Section 4, First-line pharmacologic management. Let's see how we build an evidence-based, stepped treatment protocol. Walk with me through this highly practical 4-step approach. Step 1 is baseline counseling. Think heat application and exercise. Step 2 is initiating NSAIDs or hormonal contraceptives, depending on patient preference and contraceptive needs. Step 3 is combination therapy, using both if monotherapy just isn't cutting it. And Step 4, which is absolutely vital, is to strictly reevaluate at 3 to 6 months. You want to trial the therapy for 2 to 3 cycles before escalating, but you never, ever want to leave a patient languishing on a failing regimen for years. Now, before we jump straight to the prescription pad, the data reveals something fascinating about baseline counseling. Lifestyle interventions actually carry real evidence-based weight. Regular aerobic exercise directly correlates with a reduction in menstrual pain severity. Patients who exercise consistently, say 3 to 5 times a week, fall heavily into the no pain or mild pain categories. Exercise improves pelvic blood flow and helps mitigate that ischemia-induced hypercontractility we talked about earlier. When we do move to pharmacotherapy, NSAIDs are a first-line powerhouse. But a really useful clinical pearl from the guidelines is how we actually schedule them. Instead of telling patients to take them as needed once the pain is already severe, the protocol suggests starting a phenylpropionic acid, like ibuprofen, 400 to 600 milligrams, 1 to 2 days before the pain typically begins, and dosing it round the clock. If ibuprofen fails after a few cycles, you pivot to a phenamate class NSAID, like mefenamic acid. Phenamates are uniquely awesome because they don't just inhibit prostaglandin synthesis, they also block the action of the existing prostaglandins right at the receptor level. For patients who desire contraception or those who fail NSAIDs, hormonal options are fantastic. Estrogen-progestin methods, like combined pills, patches, or rings, suppress ovulation and thin the endometrium. A thinner endometrium means less arachidonic acid substrate, which directly equals fewer prostaglandins. On the flip side, progestin-only methods, like the 20 microgram levonorgestrel IUD, are excellent for inducing profound endometrial atrophy and achieving amenorrhea in a significant portion of users by year 1. Section 5. Escalation in refractory cases. So, what happens when our patient is tried round-the-clock ibuprofen and cyclic pills for 3 cycles with absolutely zero relief? A really simple, safe, and highly effective escalation step we find in the protocols is continuous cycling. Instead of the standard 21-day active, 7-day placebo dosing, just prescribe 84 active pills followed by 7 placebos, or honestly, just have the patient skip the placebos entirely. By minimizing the frequency of menses, you directly minimize the frequency of their dysmenorrhea and significantly improve their day-to-day function. If the pain stubbornly persists, we escalate to second-tier interventions. Transcutaneous electrical nerve stimulation, or TENS, is a great non-pharmacologic adjunct that alters pain signaling from the uterus. If the patient strongly wishes to delay surgery, and we obviously must carefully consider their immediate fertility goals here, empiric treatment with GnRH analogs like oral elagolix or injectable leuprolide can be utilized to induce a hypoestrogenic state. And finally, if they are still suffering, we move to a diagnostic laparoscopy. The diagnostic yield here is massive, and it really underscores why laparoscopy is so absolutely critical in this pathway. 70 to 80% of patients with persistent pelvic pain, despite 3 to 6 months of targeted NSAID or hormonal therapy, are ultimately diagnosed with endometriosis at laparoscopy. Let that sink in. That is a crucial statistic. It serves as a stark reminder to all of us that we must proactively hunt for endometriosis when our first-line therapies fail. Finally, for a small subset of patients who have exhausted all medical and second-tier options, we look at definitive endpoints. Endometrial ablation can be highly effective specifically for bleeding-related dysmenorrhea in patients who absolutely do not desire future childbearing. And ultimately, a hysterectomy remains the definitive surgical management for those who have completely finished building their families and continue to have refractory, debilitating symptoms. I want to leave you with this final, provocative thought to wrap up our explainer. Are we, as healthcare professionals, normalizing our patients' menstrual pain instead of actively treating it? Historically, severe cramps have been brushed off as just a normal part of reproductive biology, but we've just seen the complex ischemic pathophysiology, the incredibly high risk of underlying endometriosis, and the extensive evidence-based toolkit we have at our disposal. It's time we stop dismissing this pain. Let's use these structured clinical workups to validate our patients' experiences and actively restore their quality of life.